So respiratory failure basically can be classified as acute or chronic. The clinical presentation of ARF is obvious because a patient who is normally breathing, suddenly they catch up breath, they are not able to breathe. It's going to be extremely dramatic there, and your ABG is going to show you an obvious differences in the PaO2 and PCO2. So to identify an acute respiratory failure is going to be very obvious. But acute or chronic respiratory failure represents an acute iteration in the presence of pre-existing pulmonary diseases or pre-existing chronic respiratory dysfunction. Okay, so this has to be identified. You should know the baseline status of the patient, whether the patient is a COPD, whether the patient is an asthmatic, what is the previous PCO2, what is the acceptable pH of this patient, has already been the buffer system in play in this patient. All these things comes to role when you're dealing with the acute and chronic respiratory failure patient. And third, chronic respiratory dysfunction. That may presents with markers of chronic hypoxemia. For example, to compensate for this kind of hypoxia, there will be increased RBCs, increased hemoglobin, that's polycythemia, or there will be increased pressure over the right side of the heart, causing carpulmonale. All these things is a marker that you're handling a chronic hypoxemia patient, right? So you can classify acute respiratory failure into acute and acute on chronic. And the third variety is a totally different one, which is a chronic respiratory dysfunction. So ARF has been classified as two types, hypoxemic or hypercarbic, right? More recent classifications categorize ARF into 4 different types based on mechanism of hypoxia. So now coming to the hypoxia proper, the respiratory failure proper, there should be an issue with oxygen or there should be an issue with carbon dioxide primarily. Then only you call that a respiratory system has gone in for failure, right? Either there should be a failure in oxygenation issues or there should be a failure in removal of carbon dioxide issues. This is why you call a patient in respiratory failure at all, right? So based on this, you can classify the acute respiratory failure into 4 types. Type 1 or the classic hypoxemic respiratory failure. The type 1 acute respiratory failure is actually most common form of respiratory failure and is defined as PaCO2 of less than 60 mmHg. It actually decreased PaCO2 because there is no adequate oxygen for the patient to breathe. They will start breathing on the very higher side, so they will start washing out the carbon dioxide. So you might see a patient with a normal or a decreased PaCO2 also. The analysis of ABG and calculation of the alveolar arterial gradient is very important in assessment of type 1 acute respiratory failure. Understand, as I told you, there is an alveoli, okay, and there is a capillary membrane and there is blood vessel, right? So now you need to know what is the PaO2 minus PaO2 difference, okay? The partial pressure of oxygen in the alveoli minus the partial pressure of oxygen in the artery, okay? So what is the gradient? What is the difference? The usual difference, the AA gradient is somewhere around 5 to 10 mmHg. If this gradient is more, then you know that the difference between the oxygen in the alveoli and the difference in the oxygen in the blood vessels is going to be grossly different. It means that whatever oxygen present here is not entering this way, okay? For that reason, you should know how to calculate a AA gradient, okay? You can use the Metcal formula or Metcal app at the bedside for every patient you see, okay? So once you diagnose as an increased AA gap, then you know it is not a hypoxia where the inhaling oxygen is not an issue, right? The oxygen has adequately reached the alveolus, but it is not getting transmitted. So you can identify at what level is this hypoxia. Is it beyond the alveolar level or before the alveolar level? Whether the oxygen which you are giving itself is less, whether it's like a high altitude hypoxia or there's an obstruction in the bronchus, all these things can be easily diagnosed when you come to know what is the AA gradient or the AA difference, right? So in hypoxia, when you take an ABG, when there is a hypoxia on the first place, and it's a pure hypoxia without any CO2 retention, then it is must to calculate the AA gradient. The normal AA gradient is around 5 to 10 mmHg. If anything that is more than this, you can consider that there is an issue in the oxygen getting transmitted from alveolus to the blood, okay? It is in this parameter. It can be either a pneumonia, it can either be a stiff lung, it can either be a capillary membrane disease like interstitial lung disease, it can be a pneumonia, or it can be a blood related issues like hemoglobinopathies or low hemoglobin, low anemia sort of things. The primary abnormality is located in one of the 3 sites which I mentioned now. 1, inadequately oxygenated alveoli, for example due to low FiO2 or alveolar collapse or the presence of alveoli filled with fluid, debris and blood, okay? So basically the alveoli has some issues. In that case also there won't be adequate oxygenation to the blood. Compromised transition of oxygen from the alveoli to the blood, Okay, from here, it is not going to the blood. Okay, it is because of interstitial process or pulmonary vascular diseases. Next is compromised ability of the blood to become oxygenated. The hemoglobin itself is injured, or it's not proper, or there is no adequate blood supply to that particular area. This is because due to obstructed blood flow, shunting, low hemoglobin concentration, or the presence of dysfunctional hemoglobin. All these things can cause hypoxia. Second is type 2 or hypercapnic respiratory failure. Understand, unless there is a respiratory pump failure, it is difficult to get a hypercapnia, right? So, type 2 acute respiratory failure, where the PaCO2 is more than 45 mmHg, this represents a failure of the lungs to remove sufficient amount of carbon dioxide, and is characterized by decreased minute ventilation. Understand, how do you bring out the carbon dioxide? Either taking a deep breath or increasing the respiratory rate. Okay, so tidal volume multiplied by your respiratory rate gives you a minute ventilation. So this is what you're worried about. When the minute ventilation goes down, either because of decreased tidal volume or because of decreased respiratory rate, then eventually there will be buildup of carbon dioxide, right? An increase in carbon dioxide leads to hypoxemia. Okay, so this is because the carbon dioxide itself displaces O2 effectively from the alveolar partial pressure of oxygen and gets reduced. So this kind of low oxygen because of high CO2. Okay, so there is an issue. So the carbon dioxide gets increased. Because of high carbon dioxide, there is hypoxemia. This hypoxia usually responds well when you give supplemental oxygen. Okay, if there is hypoxia because of hypercarbia, this oxygen usually responds very well to your supplemental oxygen, not like your type 1 respiratory failure. So in contrast to some cases of type 1 respiratory failure, hypoxemia in type 2 respiratory failure is easily corrected with supplemental oxygen. This type of respiratory failure is frequently due to acute or chronic neuromuscular dysfunction or inability of the airway or lung to ensure adequate ventilation or CO2 exchange. Something wrong with the medulla or the brain, or through the muscle layers, or the muscle capacity to breathe properly, or electrolyte deficiencies, or the tract, the outflow tract is obstructed, the patient is not able to bring out adequate carbon dioxide. So now, you have a patient who have a respiratory issues. You need to know that the normal PaCO2 is around 40 mmHg, right? 35 to 45. The normal pH is 7.40, 7.35 to 7.45, and the normal bicarb is around 24 milliequivalents per liter, right? So now, when do you call it as a respiratory acidosis? If it's going to be respiratory acidosis, carbon dioxide should increase, right? So how are going to be the compensation? For every 10 increase in carbon dioxide, the pH is going to drop by 0.08 in acute respiratory acidosis. If it's going to be chronic, for every 10 increase in carbon dioxide, pH is going to drop by 0.03. Meanwhile, the compensation of bicarbonate is for every 10 increase in carbon dioxide in acute condition, the bicarb will increase by 1 milliequivalent. For every 10 increase in carbon dioxide in chronic cases, bicarb will increase by 3.5. Okay, for example, now my carbon dioxide, right, my carbon dioxide is 50, it has increased by 10. So in acute condition, what do you expect the bicarbonate to be? I'm going for acidosis, so metabolic should go in towards alkalosis. So bicarbonate should increase. So 24 plus 1, 24 plus 1. So bicarbonate should be around 25, right? If it's going to be chronic, what will happen? 24 plus 3.5, 27.5. This will be my expected bicarbonate in case of chronic respiratory acidosis, right? So now, coming to the alkalosis part, the patient is breathing very fast and the PaCO2 has dropped less. What will be the compensation, right? If for every 10 mmHg drop in PaCO2, for acute cases, the bicarb also losses by 2. And in chronic cases, bicarb will be lost. For every 10 CO2, 5 of bicarb will be lost, right? For example, now I have a PaCO2 of 30 mm. So in acute condition, I have a drop of 10. So every 10 there is minus 2. So I will get a bicarb of 22. In chronic condition, for every 10 there is minus 5. So I'll get a bicarb of 19. 24 minus 5 is 19. So this is how you need to calculate for the compensation, right? The same is true for the pH also. So now anything more than this, you need to suspect there is superadded secondary abnormality also.